They told you it's burnout. They lied. It's nurse trauma. Your body never lied. The system did. I'm Dr. Lorre Laws. Let's heal the real root cause. Since nursing school, you have studied, practiced, and been evaluated on patient-centered care. It's in your facility's mission statement. It's on the Joint Commission scorecard. It is the standard against which your clinical performance is measured. And it's all a lie, not because you stopped caring about patients, but because the business model was never built around patients. It was built around maximizing profits on the backs of nurses who are considered property, chattel, part of the room charge, no different than the bedside table or the urinal sitting atop it. Budget-centered care is the new patient-centered care. Every staffing decision, every denied break, every mandatory overtime shift, every benefit that disappeared during contract negotiations, each runs through the same calculation. What is the minimum labor investment required to move the maximum number of patients through this unit? That's not patient-centered care. That's budget-centered care with better marketing. And there's a body count. Today, I'm going to show you where all four forces originate: the staffing shortage, being stretched to the breaking point, the sickness, the suffering. They do not have separate causes. They have one dark root, and all of them together are coalescing and creating the nurse health crisis. I'm coming to you after a contemplative Saturday morning on the Olympic Peninsula. It was one of those overcast mornings, moisture in the air that wasn't quite a drizzle, and I was really missing my mom on the weekend of her first heavenly birthday. As is my practice, when I'm feeling all the feels, I took to nature. The trail I randomly selected from maps ended at a bird sanctuary, a little mini preserve with a wonderful coffee shop. It felt like divine orchestration. I bought my mom's favorite latte and pastry and sat by her beloved birds. It was a beautiful and deeply healing morning as we enjoyed one another's company from different dimensions. Towards the end of that latte, my mind started to drift back to work. How to say what needs to be said, to teach what needs to be taught, and to do what needs to be done. I reflected on the deep and deeply painful conversations from my nonprofit's private community and those sessions, and the email correspondence I had with nurses from 5 continents all over the past few weeks. The same suffering. One of the 4 converging forces was driving the nurse health crisis. The suffering these nurses shared with me was not random. It was not individual, and it was not new. Nurses on 5 continents in different healthcare systems, speaking different languages with different patient populations, are all naming the same root cause: the suffering of nurses, the suffering of their loved ones, and the suffering of those in their care. Nurses are caught between what we're trained to do and what the system will allow us to do, between ethical responsibilities, clinical conscience, and the resources available, between the care that needs to happen and the resources that will never come. This gap is not burnout. It is not compassion fatigue, and it does not come from nurses or the profession. It comes from the business model that's operating inside. In issue 85, I laid out 4 forces converging on nursing right now: the staffing shortage, stretched to the breaking point, the sickness, the suffering, all coalescing to create a nurse health crisis. Since then, we have tracked how each one of those factors plays out. The hemorrhage of 287,000 nurses that walked from hospital rooms in 2024 alone. The nurses who stayed, who are being punished for advocating. The occurrence report that only runs in one direction. The 3-word playbook that keeps nurses compliant and calls it care. Well, today I'm going to show you where all those forces originate. And they don't have separate causes. They have one dark root cause. Let's talk about the first force, the staffing shortage. There are 5.6 million actively licensed registered nurses in the United States right now. The Bureau of Labor Statistics reports 3.4 million jobs. That means that 2.2 million licensed nurses have stepped out. This is not a pipeline problem. It's a mass exodus, a hemorrhage. Researchers at the University of Pennsylvania published a 2024 study of nurses who actually left the profession. The top reasons after retirement were insufficient staffing and burnout, which we all know now is not really burnout, it's nurse-specific trauma. Not a career change, not a lack of passion. Working conditions drove nurses from the profession. The 2024 National Nursing Workforce Survey reports that 40% of nurses plan to leave within the next 5 years. Why are they leaving? They're citing structural issues, short staffing, high workloads, dangerous staffing levels. Dr. K. Jane Muir of the University of Pennsylvania said it plainly. There is not a nursing shortage. It is a nurse's refusal to be a part of the system that puts profits before safety. Or, as I put it, it has become physiologically contraindicated for nurses, millions of them, to remain in practice under these conditions. The allostatic load of nurse-specific trauma has become untenable, and it continues to drive more and more nurses from the profession and will continue to do so until we address the structural issues in healthcare. The system calls it a nursing shortage, a term used to empathy manipulate nurses into staying, but there isn't a nursing shortage. Budget-centered care is manufacturing a shortage and then uses it to guilt nurses into staying. Now let's look at the second force, being stretched to the breaking point. Hospitals and health organizations are stealing time, which translates to wage theft from their nurses. They require nurses to be there 30 minutes before the shift starts, but won't allow them to clock in until 5 minutes before shift start. They require nurses to take 30-minute lunch breaks and then require them to take a phone or a pager and be available for questions while on their break. And if the clinical situation is such that the nurse can't take their lunch break, well, they get docked for that time anyway and then get written up for not being a good culture fit. Nurses are stretched to and beyond their breaking point, and then they're getting charged or penalized for it. Wage theft. It is more common than you may think. A 2024 federal lawsuit against HCA Healthcare, the largest for-profit hospital system in this country, alleged that over 18,000 workers were shorted on pay through time-rounding practices that operated in the employer's favor more than 70% of the time. The same lawsuit alleged automatic lunch deductions, whether a break was ever taken or not. In January of 2026, over 800 nurses at MedStar Washington Hospital Center filed a formal complaint with the D.C. Attorney General alleging altered time cards and systematic off-clock work expectations. A union official put a number on it. 30 unpaid minutes a day adds up to 6 full shifts of free labor every year. Pennsylvania nursing facilities were ordered to pay $36 million in overtime violations. 786 nurses in Minnesota reached a $575,000 settlement over auto-deducted meal breaks they never got to take. Nurses at Endeavor Health in Illinois filed a suit alleging they were required to arrive 30 minutes early, unpaid, and to stay up to 2 hours past their shift ending without compensation. These are not exceptions. It's standard operating procedure. And these procedures, well, they're making nurses sick, which is our third force, the sickness. Nurses are the sickest professionals in healthcare. 54% are overweight or obese. 67% report depression or anxiety. Female nurses die by unaliving themselves at nearly twice the rate of the general female population. 77% experience musculoskeletal disorders annually. These are not statistics about a profession that is being supported. These are statistics about a workforce that is being consumed. And when nurses get sick as a natural response to working condition, the system starts cutting their healthcare benefits. During a recent strike at Kaiser Permanente, Mount Sinai, and Henry Ford Genesis, nurses were on the picket lines highlighting exactly this point. These hospitals moved to slash medical coverage, pension benefits, and retirement plans. Working conditions create nurse illness, and instead of fixing these conditions, they slash the benefits that the nurses need to access the health care to keep them healthy and well. All while the nurse is completing the required computer-based training on the importance of self-care and resilience. The system says one thing and does another. Nurses are considered part of the room charge, not providers of care. When you look at the spreadsheet, the profit and loss, the income and expense statement. So if you're no different than a bedside table or the urinal sitting atop it, your health is inconsequential to the bottom line. Healthcare benefits are a labor cost. The system makes nurses sick and then charges them more to be sick, or withdraws their ability to access healthcare services when they need to heal. A Mobius loop with no exit. Which brings us to force 4, the suffering. Suffering does not appear on a balance sheet, but it moves through households like a current. The nurse comes home depleted, dysregulated, silent, and the family absorbs it. They rearrange their whole life around it. Research now confirms what families already knew. A 2025 University College London study found that nearly 34% of household members of healthcare workers report secondary traumatic stress in the severe range. Female spouses and partners of nurses in clinical roles showed the highest rates. The study concluded that while household members were trying to support the healthcare worker, they were simultaneously at risk for developing trauma themselves. The institution sent the trauma home with the nurses, and it doesn't pay for what arrives there. And the patients, well, they're suffering too. A 2024 Stanford meta-analysis of 85 studies covered 288,000 nurses found that nurse burnout is directly associated with more hospital-acquired infections, more patient falls, more medication errors, and more adverse events across every geography, age group, and level of experience studied. A separate review of 27 longitudinal studies determined that high nurse-patient staffing ratios caused an increase in patient mortality. Little room for doubt, according to the author of that study, that there is a causal relationship. A 2025 systemic review of 20 studies in ICU settings found that safe nurse staffing ratios were associated with a 14% reduction in hospital mortality and a 20% improvement in infection prevention. And also it found that by adding one more patient to a nurse's staffing assignment, well, that increases in-hospital mortality by 13%. The institution made that ratio decision to add another patient, to stretch a nurse even more thinly. The institution makes the decision, and then the patient has a 14% increased risk of mortality and could die from it. And the family grieves, and the nurse carries the trauma. The family of the nurse and the patient gets vicarious or secondary trauma. Budget-centered care generates profits for the C-suite and suffering for those in its care or employ. Now, before I continue, I just want to tell you about something I built specifically for nurses living inside what I just described. You now have a name for what has been happening. It's called budget-centered care. You can see the 4 forces and where they came from, and that awareness matters. And your awareness alone will not heal a nervous system that has been running on threat and is stuck in survival mode for years. This is exactly why I created the free resource vault that has many educational recordings, practices that you can access on an app 24/7, and a community that includes free weekly live calls with me. So if you find yourself in these situations, you can come, you can get your questions asked, you can walk through your nervous system process, and you can get the tools that the system never wanted you to have. Because, in all honesty, no one is meant to heal alone. Optimal healing happens in relationship when we can co regulate with one another. So go ahead and take a moment to hop over to my website at drlorrelaws.com/vault, and you can get yourself enrolled in both the resource vault and the community at the same time. Now, let's get back to what's really going on. So what we're experiencing here, it's not stress, it's architecture. I want to be very precise here because precision matters. What I am describing in these 4 forces and budget-centered care, it is not burnout. It is not compassion fatigue. It is not a stress response that lighting a candle, doing a yoga practice, or clicking through a resilience computer-based training is going to even touch. And for those of you who have been with me for a while, you know it's not burnout. You know that burnout is a symptom cluster of nurse-specific trauma. In a study I conducted prior to leaving academia, I discovered that 76% of what the healthcare industry calls burnout, well, those symptoms map directly to trauma responses, not stress, not compassion fatigue, trauma, nurse-specific trauma. In 2022, Dr. Karen Foli at Purdue University published her middle range theory of neuropsychological trauma. Her peer-reviewed framework identifies the trauma types that are nurse-specific, not general workplace stress, not occupational trauma in a very general, non-specific lens, not the universal experience of hardship. These trauma types map exactly to budget-centered care. Every single time. Most of nurse-specific trauma is avoidable and system-induced. And everything maps directly at root cause, the 4 forces, the nurse-specific trauma, to, you guessed it, budget-centered care. Insufficient resources, a very substantial part of avoidable nurse-specific trauma. Foli defines this as the trauma that results when nurses are prevented from fulfilling their moral responsibilities due to lack of time, personnel, and resources. That is a clinical definition for a budget decision. When the ratio is set at 6 patients per nurse because 4 is too expensive, when you cannot get to every patient, when you know it, you document it, you advocate for change, and nothing changes. That gap between what you are required to do and what you are resourced to do is not a system error. It's insufficient resource trauma. It's peer-reviewed, and it is producing measurable physiological and psychological harm. And the other kind of avoidable nurse-specific trauma is called system-induced trauma. And this is the trauma that is produced by institutional policies, workflows, and responses that harm the nurses working within them. The occurrence that is issued to a nurse that runs only one direction with no system accountability. The mandatory trainings that are scheduled right over the direct patient care shifts. The PTO that's stolen without accountability, the retaliation for advocacy. I documented all of these conditions and the nurse case studies that went with them in episodes 87, 88, and 89, if you want to go back and take a listen. These are not management failures. These are policies. They are written, approved, and defended by people in budget-centered care meetings. System-induced trauma is what budget-centered care produces at the unit level, shift by shift, nurse by nurse. Budget-centered care is not accidentally generating trauma. It is engineering the nurse staffing crisis, being stretched to the breaking point, nurses being the sickest professionals in the hospital, and the mass suffering of patients, nurses, and their respected loved ones. So I know that you know, and now we all have brought light to budget-centered care. And it is not because of a broken system. The system is working exactly as designed. The staffing shortage, the breaking point, the sickness, the suffering, these are not failures of the model. They are predictable outcomes of a business model that has never once listed nurse safety or professional well-being as a line item, but rather reduces nurses to property, chattel, part of the room charge. And every nurse who has ever been told to do more with less, to work through a break, to absorb an unsafe assignment, or received an occurrence for a leadership or system failure, you live and breathe budget-centered care. You already knew this, you just didn't have a name for it, but now you do. In the next episode, I'm going to lay out why knowing that it's not burnout, that it's nurse trauma, is the single biggest opportunity for nurses to reclaim their health and their power back from the system that steals it all under the guise of an empathy manipulating nursing shortage, quote unquote. Because knowing the name of what is really happening matters. Knowing that budget-centered care is at the root cause of everything matters. And there is something upstream of that awareness that is keeping nurses stuck, something that the system is counting on, and it's counting on you not knowing it. So stay tuned. So as we wrap this episode, give some thought to how is budget-centered care affecting you? The insufficient resources, the system that punishes advocacy, or watching patients bear the cost of decisions made in a budget meeting. Send me a message, DM me on socials, drop me a note on my website. I read and respond to every message personally. And if you know a nurse who is living inside these four forces right now and is struggling as a result of budget-centered care, please share this episode with them. They need to know that they're not alone and that they are not the problem. Are you ready to understand exactly how budget-centered care has taken up residence in your nervous system? Well, take the free 2026 Nurse Trauma Assessment at drlorrelaws.com/assessment. It takes 2 minutes, and I'll send a personalized report straight to your inbox showing exactly where you are and what you can do about it. From my healer's heart to yours, and until next time, namaste.